Hi everyone. Hi, my name is Swapnil and welcome to this new venture from Critical Care Education, that is free open access ICU education. And today this is the first pencast in the fellowship preparation series, and what we're going to discuss today is how to approach a hot case. Now, hot case traditionally been one of the most difficult part of the fellowship exam, and a lot of people actually struggle to pass the hot case, and including myself, I did struggle. So I really want to kind of share what I learned from my experiences, but also a lot of this video comes from the insights that I gained from the various fellowship examiners who helped me to get through this exam. And it seems sometimes artificial to do a hot case because traditionally when we do rounds, we don't approach the patient in a very similar manner as we approach the patient in an exam situation. I think that's where a lot of people struggle to understand what it takes to pass the hot case. And I guess the key thing is to start practicing the same approach when you're examining the patients on the round. And I think once it becomes a second nature to you, that's how you examine every single patient in ICU, the fellowship hot case or fellowship exam is no longer going to be difficult for you. So quickly to start about the hot case, so usually you got 10 minutes to assess the patient, and then there's a 2-minute time outside to read the stain and get into that kind of zone. The 2-minute preparation time is really important. So what I want to share is, it's like you are an actor and you are going to perform on stage. Think about that, and I think that helps you to get to that mindset, get into that preparation phase. And that's why I came up with mnemonic for the approach towards the hot case, and that is called as pose. As if you are posing. Okay, so what is the P stands for? So the P stands for the preparation phase. And this is very crucial, because before you begin, and if you look at any actor who perform on the stage, they spend at least an hour or 2 hours in getting into that zone and preparing themselves. And I think I'm not talking about the pre-exam preparation, but on the day where you are outside the patient room in new ICU, which is not familiar to you. I think that 2-minute preparation is really important. And unfortunately, you don't have an hour-long time to prepare and do exercises, but like what actors do, but then you got only 2 minutes to prepare yourself. And I think that's still not bad. So what you need to consider in the preparation phase is, first of all, calm your nerves. Just breathe. You will be given a stain, say for example 60-year-old male, day 4 or day 5 in ICU after sustaining a polytrauma, and you've been asked to see this patient and come up with issues and the management plan for next 24 hours. So this is again a very stock standard stain. Now, what is important in this stain is key things that you need to pay attention to is, first of all, what is the question? Because at the end of the 10 minutes, you need to answer the question. And a lot of people forget the question. They kind of go in, examine the patient, and then they come out, talk something random about something else. And I think that's where people often fail their hot cases. So the question is really important. What exactly examiner is trying to ask here? The second important thing about the preparation is to pay a lot of attention to the details. And the details not necessarily going to be very difficult. So preparation, as I said, first of all, look at the question. Then second is the patient details. Now the patient details are important in terms of what's his age, what's his X, what's his name, because a lot of time people get blank and then they go in the room and they don't know the patient's name, and that's very awkward. So make sure that you know the patient name by heart before you enter the patient's room. And I guess the age and sex is important because the comorbidities, the prognostication, they all are associated with age. So age is really important. And the other thing is going to be your day in ICU. Okay. So day in ICU is important because, again, the shorter the stay, that means patient had just come out of the acute stabilizing phase. While if it's day 14, day 15, the whole discussion about that VIVA or the hot case is going to be around the prognostication or say for something like performing the tracheostomy or not. So day in ICU is a very crucial. Now, the other things to kind of pay attention to is try to identify what type of case is this. And I'll talk about that in a detail, but usually you need to kind of select a template that you're going to use when you go into the room and start examining the patient. And I'll talk about this here briefly, but I will explain that when we dive deeper. So the template is really important because there are 3 types of patterns that you will get in the fellowship exam. The first one is neuro case. Now, when I say neuro case, that's going to be either say traumatic brain injury or stroke or any like GBS, or any sort of neurological problems. Neuro cases are usually tricky to deal with. And I think that's why you need to have a set template how to approach a patient with a neurological problem. The second template is a non-neurological patients, and that includes your cardiovascular, respiratory, and abdominal problem patients. And they have a kind of set template about how to approach, how to examine. Again, I will explain those templates in detail in next video. And trauma, and third one is a trauma template, because polytrauma patients, they need to be examined in a certain way, because you can't really apply a general exam template or the neuro template. You need to have the kind of trauma template. Now, there can be an overlap of polytrauma and TBI, but then when it's a trauma, usually you stick to the trauma and then do the neurological examination or use the neuro template on the top. So usually these are my kind of 3 broad templates. So just to summarize, so one is neuro, one is non-neuro, and the third one is trauma. Okay, so these are the kind of my main templates that I used, and feel free to change those templates. The other thing about the preparation is start thinking about what is going to be answer to your question. Most of the time people think that they need to examine the patient before they kind of start thinking about answer, and that's the myth. Just going back to the template that or the patient that we chose at the beginning, 60-year-old male, day 5 after traumatic brain injury in ICU, and you are asked to come up with your management issues and management plan for next 24 hours. Now, if you think about it, when you are actually examining the patient, like you are trying to just put dots together, but first of all, you are going to see 60-year-old, which is not old, which is like a middle-aged, youngish. We call it as a young patient, but it's not going to be a prognostication problem. But it's a 60-year-old, so that's important. Day 5 in ICU. So in traumatic brain injury pattern, usually you see that this is a phase where they might be struggling with ICP issues. They might be struggling with some sort of fever issues. They might be struggling with obviously not waking up despite of sedation for last couple of days, or they might be ready to go for some CT transport. So just start thinking about what you normally expect at day 5 in any traumatic brain injury patient. When you walk into the room, and if you don't find which is what we expected, then you need to start questioning yourself. Okay, there's something is not fitting here, what I normally see in my day-to-day practice with the similar patients. So, and that's why I call this as a critical care patterns. You need to identify the pattern and you need to follow that particular pattern and start thinking about the answer before you walk in that room. Okay, what am I going to expect? What am I going to find? And how am I going to structure this answer? So just to kind of get into that zone, start thinking about it and start preparing about it. So that's why the preparation phase is really, really useful. But 4 main things that you need to think about in preparation phase: what is my question? What are the details of the patient? How many days this patient is in ICU? And what template am I going to use? If you keep it simple to those 4 aspects, I think it kind of fits within that 2 minutes. It's not too much to think, and it just keeps emphasis on what you're going to do next now. So it's just like getting into that groove. The next phase is going to be the observation phase. Now the observation phase is again very simple. Usually you got 1 to 1.5 minutes at max to stand at the end of the bed and then follow around the room what's happening. And I recently did the museum educator fellowship, and one of the strategies that we use in that, which similarly we use in our fellowship exam, is called as VTS, or also called as visual thinking strategy. Now VTS is a very simple methodology. So what it actually does is, so you've been given a piece of art or painting or anything, and then you're supposed to have a kind of take a deep look at that painting or a picture. And usually the instructor asks you the 3 questions. So first of all, what's going on here? The second is, what do you see that makes you say that? And the third one is, what more can we find? These 3 questions are really important with your observation phase. So first question is, what's going on here? When you walk into the room, stabilize yourself and then look around the room and trying to think, okay, what's going on here? So I can see a 60-year-old gentleman lying in a bed with all these monitors attached and all this equipment attached. But also I can now start seeing some more things like, okay, the sedation is at max. I can see some more infusions there. I can see on the monitor, it's just not ECG, blood pressure and pulse oximeter, but it's actually, there is ICP monitoring. There is an AVD hanging around now. And also there is this ventilator, which is in controlled mode fully. There is no any spontaneous press. Oh, but now also when I start seeing a patient, I also start seeing that there is no bone sign on the head. And all these kind of small observations kind of point you in kind of direction where this case is heading, where this patient discussion or the problem is going to be. So all those small observations are really, really important. And when you start interpreting those patterns or synthesizing those patterns. So when you see no bone, the interpretation is, probably this patient had decompressive craniectomy. And what's the kind of scenario when you have decompressive craniectomy is when somebody has got issues with raised ICP. So then you start kind of thinking, okay, what do you see that makes you say that? So why do I say that this patient had issues with ICP? Is because I could see there is no bone sign, and that means the patient had a decompressive craniectomy. And day 5, still having ICP monitor, still having the AVD, which is continuously draining, all those patterns together. So when you say that this patient had issues with raised ICP, you need to kind of substantiate with your observation. And that's why the observation phase is really important, because within again that 1 minute, you can gain a lot of information. So you have not even touched the patient, you have not even examined the patient. So in the preparation phase and in the observation phase, within that kind of 2 to 3 minutes, you get the whole picture, what's going on here and what do you see that makes you say that. And then really the third question is, what more can we find? And what more can we find is where you need to get your S, or also called as structured examination. So structured exam is again to put things together, get an idea about what's happening here. And again, the reason it's called as structured is not because you just don't go take the sheets off and then start examining randomly from cardiovascular system and respiratory system. That's not how it's been done. So again, go back to your question. What is the key question? What type of template are you using? Okay, if it's a neuro template, you start with a neurological examination, complete the neurological examination, then go to cardiovascular examination, then respiratory, and then abdomen. There's no point in neuro patient doing the neuro exam and then doing the abdominal exam, because very unlikely there's a relation between the two systems here. So when you examine, there is a kind of certain pattern that you need to follow, and that's why it's called a structured exam. And really the exam is to fill in the gaps basically that you thought in the preparation phase or the observation phase, that okay, I was thinking that I will find these, but I really didn't find these. Okay, let's now, why didn't I find that kind of thing? And when you do the neuro exam, again, for example, you're trying to synthesize the information, because the clear difference between the medical student and the fellow is fellow should be able to synthesize and interpret the exam finding while doing the examination. So you can say that reflexes are brisk, yeah, but that's just the finding. The patient has upper motor neuron signs predominantly on the right side compared to left side, and that means my lesion will be on left side. So again, those small things you need to then start interpreting, rather than just saying, oh, I noticed the patient had a brisk reflexes. Yeah, anybody can do that. The difference between you and the medical student is then how you interpret and present that information in an articulate manner. And that comes back to the E part, that is expression. And the expression is really basically a synthesis of all the three steps above, and then trying to create a nice picture or portray an image to the examiner, and or telling the story that this is what I think about this patient. And a lot of people kind of get stuck into this one, like motherhood statement, or I had to come up with some sort of concrete answers, and if I had to come up with like list of 10 issues, not really. So the expression is, as long as you create a sensible picture or sensible story of what's going on here in this particular patient, I think that should be enough. And examiners do understand that, you got only 10 minutes to come up with the whole, and it's merely impossible in ICU to come up with entire picture. There will be some pieces of the puzzles will be missing, and always it's not possible to kind of get the whole idea about what's going on here in 10 minutes. But when you perform in this kind of structured manner, the whole sequence, you should be able to tell a story and express that, okay, this 60-year-old male who came up with trauma or sustained a severe traumatic brain injury. And now I started using the words here because I could see why it's a severe traumatic brain injury. Because this patient had decompressive craniectomy, this patient has still issues with the raised ICP, this patient has still got an EVD which is continuously draining. So I'm very comfortable to say that this patient has sustained a severe traumatic brain injury. He's a 60-year-old, already had a decompressive craniectomy. So I'm worried about this patient now, because although he's less than 70 and possible good outcomes with decompressive craniectomy, it's day 5, still having issues with raised ICP despite having a decompressive craniectomy. is still quite heavily sedated and paralyzed, I'm extremely worried. And you are allowed to show those concerns and emotions about the patient as a human being, or as if you're treating intensivist. You will be worried about this patient, about the overall prognosis, the trajectory. It's too early in the piece to prognosticate because it's day 5, but you should be able to say those things that I'm worried that this patient had still got a lot of issues to sort out. And then management aspect will go on how to manage, basically raise ICP, and then classic 3-tier or 4-tier approach with the Brain Trauma Foundation guidelines. And as long as you and there is nothing much you can do really with this now, because you already done the decompensated connect. He's already been sedated, paralyzed. He's already probably had hypertonic saline and all those things. And you need to kind of have that sensible discussion, and also bring, okay, what I will do as a treating intensivist. How I will approach the clinical problem, how will I approach the family situation, how will I deal with the surgeons who are also part of this whole picture. And once you start expressing those, your thoughts, I think that's when you know that you passed the case. Because all they want to see as a sensible consultant walking in the room, looking at the patient and coming with some sort of concrete plan, and then saying, okay, this is what I will do. And you need to own the patient in that 10 minutes. And that's what the trick to pass fellowship exam. So I hope you like this video. I will be back with the next video where we will go through the templates, how to examine each patient according to each template. Till then, goodbye. Have a nice time.